Welcome everyone to the inaugural lecture for Clinical Lectures in Oncology. This particular seminar is devoted solely to presentation and discussion of advancements in clinical research. We're very grateful to Dana-Farber's former president, Dr. Edward Burns, for his establishment of this lecture, and we look forward to more discussion on clinical research in the future. Today, it is my true privilege and pleasure to introduce the inaugural speaker for this series, Dr. Kim Ng, Associate Professor of Medicine at Harvard Medical School. After stellar training at Yale University as an undergraduate, University of Pennsylvania School of Medicine, and UCSF as a resident, Dr. Ng joined the Dana-Farber Harvard Cancer Center Hematology Oncology Fellowship Program, while she also completed a Master's in Clinical Effectiveness at Harvard School of Public Health. Since then, Dr. Ng has been faculty in the Division of Gastrointestinal Oncology at the FCI, where she has served as Director of Clinical Research and currently serving as Director of Translational Research, co-director of the Colon and Rectal Cancer Center, and Associate Division Chief. Dr. Ng is an international clinical research leader and the principal investigator of several highly innovative clinical trials investigating novel targeted therapeutics and vitamin D supplementation in colon cancer, work that has been supported by numerous NIH grants. Moreover, she has pushed the envelope in colorectal cancer translational research, both in preclinical modeling of the disease, as well as identifying novel biomarkers of treatment efficacy and toxicity, including the microbiome. She's the founding director of the Young Onset Colorectal Cancer Center at the FCI, which is one of the first such centers in the world. And she has championed, in addition to caring for younger patients, raising awareness for this epidemic and elucidating the causes of young onset colorectal cancer, which is the subject of her talk. Please, everyone, submit your questions through the Q&A tab. Dr. Ng, thank you for joining us.
Thank you so much for that nice introduction. And it really is an honor to be the inaugural speaker for what I know will be a really impactful clinical lecture series in oncology. So as Dr. Giannakis mentioned, the topic of my talk today will be about young onset colorectal cancer. These are my disclosures from the past year, none of which are directly relevant to this talk. And this is the brief outline of what I will be speaking about today. I will start by reviewing some background statistics and trends regarding colorectal cancer. I will talk about the development and launch of our Young Onset Colorectal Cancer Center at Dana-Farber. And I'll review some of the studies we've done looking at the epidemiologic risk factors for this rising trend. And then I will end by reviewing some of the ongoing and future research studies that we are currently conducting. So to start with some background, for those of you who are not familiar, colorectal cancer is a huge problem in the United States as well as globally. It is currently the third most common cause of cancer in both men and women, with 150,000 new diagnoses expected in the year 2022. It is also a significant cause of cancer mortality. Currently, if you combine men and women, it is the second leading cause of cancer death in men and women following lung cancer, with 50,000 deaths estimated to occur in 2022. If you focus on the bottom graph, there is a silver lining here in that with the advent of colorectal cancer screening and increased compliance and uptake of screening, this disease has been declining in terms of incidence in people over the age of 50 who were previously the screening eligible population. Unfortunately, for those individuals under the age of 50, as evidenced by the curve here, after a period of decline and then relative stability, since the mid-1990s, we have been seeing a steady rise of about 2% per year in the incidence of both colon and rectal cancer in both men and women under the age of 50. The incidence, interestingly enough, is increasing the most rapidly among non-Hispanic whites. There are well-known disparities in the incidence and mortality of this disease by race and ethnicity, which we will go over in a little bit. But in terms of young onset colorectal cancer, the curves do seem to be rising most steeply among non-Hispanic whites, which has led to somewhat of a narrowing in the gap in terms of the incidence and mortality of this disease between non-Hispanic white and non-Hispanic Black populations. The incidence of this disease is also increasing throughout the United States. Out of 47 states with available data, the incidence of young onset disease has been documented to be increasing in 40 out of those 47 states. And many of the states are actually out in the West, where it's typically associated with a healthier outdoors lifestyle. This is also happening globally, not just in the United States. You can see here curves from several higher socioeconomic status countries, which are where this seems to be a predominant problem. In those countries and continents with national colorectal cancer screening programs, you can see that in individuals over the age of 50, the incidence of colorectal cancer has been declining nicely in response to these screening programs. But in those individuals younger than 50, the same pattern is emerging with a rising incidence about since the mid-1990s, early 2000s. Also very interesting, there have been stable trends documented in Mediterranean countries as well as in the Far East, although we are now starting to see reports that it is increasing in those countries as well. But clearly diet and lifestyle factors, which we know are strongly linked to colorectal cancer, are quite different in those regions of the world. And then unfortunately, this trend is not isolated in time either. This will continue to increase, and it is estimated that by the year 2030, nearly 11% of all colon cancers will be diagnosed in people under the age of 50. And a shocking quarter of all rectal cancer cases will be happening in very young individuals. So the reasons for these varying trends and incidences of rise are unknown. Although it is much more common to have a family history of colorectal cancer and to find a germline genetic predisposition to colorectal cancer when somebody is diagnosed at a young age, you can see from this pie chart here that the vast majority have no obvious risk factors for developing this disease. And so 56% of the cases that are happening in young people are considered sporadic. We do have some clues as to what might be causing this, and we're pretty confident that it isn't a shift in germline genetics or the prevalence of germline hereditary syndromes. Age period cohort modeling has demonstrated that the cohort effects greatly outweigh period effects, such that compared to a reference group of individuals born in 1949, individuals born in 1990 have quadruple the incidence rate ratio of developing rectal cancer and over doubling of the incidence rate ratio for developing colon cancer. Again, this leads us to believe that it is relatively recent changes in environmental exposures that are likely leading to this rising incidence. So if you focus here on the curves on the right here, which show the mortality from colorectal cancer, you can see again that in individuals over the age of 50, which has historically been the screening eligible population, mortality has been steadily declining for several decades now. And this is not only due to advances in treatment and surgery and radiation techniques, but also to colonoscopies and colon cancer screening, which can detect colorectal cancer at an earlier stage when it is more likely to be curable. Unfortunately, in individuals under the age of 50, after a steady period of decline, we are now starting to see an uptick in mortality rates from this disease in young people. Part of the reason might be that young patients are diagnosed with much more advanced stages of colorectal cancer compared to older patients. In this survey of 1,000 young onset colorectal cancer patients, 41% reported waiting over 6 months before seeking medical attention for symptoms. When they finally did present to medical attention, 2/3 of these young onset colorectal cancer patients reported having to see 2 or more physicians prior to being correctly diagnosed with colorectal cancer. And this is simply because colon cancer is not on the radar of young individuals who are otherwise healthy, many of whom don't even know what colorectal cancer is, nor is it on the radar of the clinicians evaluating these patients when they first present with symptoms and see an otherwise healthy young person in front of them. And this led to 71% of this cohort of 1,000 young onset patients being diagnosed with stage 3 or 4 disease, which we all know is much less curable than somebody who presents with stage 1 or 2 colon cancer. But we're also beginning to suspect that cancers that happen in younger individuals may be biologically different and perhaps more aggressive than cancers that happen in older individuals. In this national registry study comparing 13,000 young adults with colon cancer compared to 37,000 older adults with colon cancer, there was a documented increased use of postoperative systemic chemotherapy among young adults, even when it was not necessarily indicated by national treatment guidelines, such as for stage 1 or stage 2 colon cancer. And when these patients receive treatment, they more often receive treatment with more aggressive regimens containing multiple chemotherapy agents. But as you can see from the curve here, these additional treatments and more aggressive treatments have not led to corresponding gains in survival among these young patients, where the survival curve completely overlaps with that of older colon cancer patients. In this series on the right here, published by Memorial Sloan Kettering Cancer Center of metastatic colorectal cancer patients, you can see here also that young patients do not have a survival advantage over older patients. And if you look at the dark red line representing the very youngest patients, ages 14 to 35, they actually have the shortest median overall survival compared to the other age groups, although this did not end up being statistically significant, likely due to sample size. We then looked ourselves at a large clinical trial cohort of metastatic young onset colorectal cancer patients. These were metastatic patients enrolled on the CALGB SWOG 80405 trial, which is the largest phase 3 trial ever conducted in metastatic colorectal cancer. And what we found was exactly the same as the other two studies that I just mentioned, where younger patients, despite receiving higher dose intensity of treatment and having fewer adverse events to treatment, do not have superior survival as would be possibly expected from a younger, healthier population. You can see here that the median overall survival of the age group of metastatic patients over 50 years old was 26 months, and it really was similar even in these younger groups. In the very youngest patients under the age of 35, you can see here that the median overall survival is numerically shorter than older patients. The same trends were seen for progression-free survival, where it does seem that the very youngest patients seem to do worse, although again, this was not statistically significant because of numbers. When individuals looked at high-risk stage 3 colon cancer patients, similar trends were seen as well, where again, despite having better outcomes with a better tolerability of treatment and higher dose intensity, there were shorter times to recurrence, particularly for the very highest risk stage 3 patients, as well as higher cancer-specific mortality for people under the age of 50 with stage 3 colon cancer compared to older individuals with stage 3 colon cancer. And we do have clues from looking at pathology as well as genomics that young onset colorectal cancer may indeed be biologically different than older onset colon cancer. The top few rows here we've already reviewed in regards to younger patients more often presenting with symptoms and having a longer duration of symptoms and time to diagnosis. But other interesting patterns have emerged where the vast majority of colon and rectal cancers that happen in young people are on the left side of the colon, with a huge number being in the rectum compared to older onset colorectal cancer patients. They also more often have signet ring cell differentiation, which is associated with more aggressive disease, as well as are more often poorly differentiated compared to tumors that happen in older individuals. And we already reviewed that most young onset patients get diagnosed with late stage colon cancer compared to older individuals. With the advent of next generation sequencing techniques, groups have started to look at whether there are genomic differences in the tumors that happen in younger people compared to older people. And in this report from the Foundation Medicine database, you can see that in people under the age of 40, there do seem to be fewer APC mutations, as well as fewer KRAS mutations and BRAF mutations. Again, the differences are not striking though, and so it is probably not the case that genomics is driving this different biology in young patients. People have also looked at epigenetics, and there are some clues from small studies that show that young onset colorectal cancer may also be epigenetically different, with this series of about 200 young onset colorectal cancer patients from Argentina and Spain showing lower amounts of line 1 hypomethylation compared to older onset colorectal cancer patients. And the colorectal cancer patients who did have hypomethylation of line 1 do seem to have a poor survival. And so this certainly could be a reason why young onset colorectal cancer may be increasing, because we do know that line 1 hypomethylation is associated with Western pattern diets and sedentary activity, for example, and may also lend a potential explanation for why their survival may be worse among young onset patients. And all of this is more urgent because colorectal cancer, if these current trends continue, will become the #1 cause of cancer death in people ages 20 to 49 by the year 2030, surpassing breast cancer as the leading cause of death in these young people. It will also surpass non-Hodgkin's lymphoma to become the second leading cause of cancer in young people by the year 2040. And so all of these statistics led the United States Preventive Services Task Force to change their recommendations for the age at which to initiate screening in average risk individuals from age 50, moving it down to age 45. And these new guidelines were published in the spring of 2021 in JAMA. And I do think that we will be able to detect more young onset colorectal cancers at an earlier stage and hopefully lead to improved survival, but also to prevent colorectal cancers as the majority of these young onset patients do present in their 40s. Now, this certainly doesn't address the fact that the rates of rise are steepest in the very youngest patients in their 20s and 30s who still do not qualify for colorectal cancer screening under these new guidelines. And this just highlights the urgency at which we need to understand what the underlying causes and risk factors are so that we can adopt a risk-adapted approach to screening to identify those at highest risk. Now, just a sidebar about the effectiveness of screening, colonoscopies really do work. As public health campaigns have advocated for colonoscopy screening, you can see that the incidence rate of colon cancer has declined steadily in response. It is important to note that even in 2018 and currently still, 2/3 of the eligible screened population are not getting their colorectal cancer screening. So not only is it urgent that we get younger people to screening, but we also need to focus on this older group of patients where their risk is actually the highest for developing colon cancer and get them to their colonoscopy screenings. There are also disparities across races and ethnicities in terms of screening rates. And this is a graph here that shows the progress to getting 80% screened in every community by the year 2020, which unfortunately has not happened. With the implementation of the Affordable Care Act, this certainly has improved, but you can see that across various races and ethnicities, there are still a huge number of people who are not going for colorectal cancer screening. And this likely does contribute significantly to the ethnic and racial disparities that we see in the incidence and mortality of this disease, where non-Hispanic Blacks are much more likely to be diagnosed with colorectal cancer, including at an earlier age, and about 40% more likely to die from this disease. These disparities have unfortunately been also exacerbated by the COVID-19 pandemic, where because of various shutdowns and social distancing, particularly early on in the pandemic, there has been significantly reduced access to care. There's been delayed routine care leading to later stage diagnoses, as well as delayed and modified treatments for existing colorectal cancer patients that we fear may be leading to increased mortality from this disease that we may see in the coming years. In fact, during the pandemic, there was a 90% drop in the colonoscopies and biopsies that were performed and nearly 20,000 misdiagnoses. And so we estimate that there will be 4,500 excess deaths from colorectal cancer as a result of the pandemic. And in this nice study done by folks here at Dana-Farber, looking at cancer screenings during the early period of the pandemic, as represented by the blue bars, mid-pandemic in 2020 as recommended by the yellow bars, and then the gray bars later on in the pandemic, you can see here that mammographies and PSAs, pap smears, and lung cancer screening have started to recover as the pandemic has waned. The one that has not are colonoscopies. And so again, there are likely still many misdiagnoses out there that may lead to increased mortality and later stage diagnoses happening in the coming years. So back to young onset colon cancer, although it is difficult to receive a diagnosis of cancer no matter what age you are, we are all aware that young patients face unique challenges. In this survey of 1,000 young onset colorectal cancer patients, 85% report significant anxiety or depression. Many have to seek treatment for these disorders. 80% report having children under the age of 18, and there are significant disruptions in career and education. As I mentioned, the vast majority of these young onset colorectal cancer patients are in their 40s at the time of diagnosis, where they may also be taking care of elderly parents. And so this really is the sandwich generation where there are a lot of other life challenges happening at the time that this diagnosis is occurring. In this single institution study where young onset rectal cancer patients were surveyed about whether fertility discussions had happened prior to them initiating treatment, you can see here that a significant number were not able to talk with their doctor about the ability to have children after treatment. And the vast majority did not end up banking eggs or embryos or sperm prior to initiating treatment for rectal cancer, most often of which involves pelvic radiation, which certainly does lead to infertility. And although 50% report that they chose not to do it as the reason for not having banked, many actually reported that they couldn't afford it, or that their treatment couldn't allow it, or that these discussions did not actually happen. So in order to address all of these challenges and gaps in care, we did launch the Young Onset Colorectal Cancer Center here at Dana-Farber back in March 2019. And it does remain one of the few centers dedicated to this particular population of patients in the world. Our center has a threefold mission rooted in clinical care, raising education and awareness, as well as promoting a multidisciplinary research effort to really better understand the underlying etiology of this disease. To go into each of these missions in a little bit more detail, like with every patient seen at Dana-Farber, they're offered a multidisciplinary evaluation. One difference is that every young onset colorectal cancer patient who is seen is automatically referred for a genetics appointment, because it is shocking how many actually do not undergo germline evaluation. We also want to be sure that they are comprehensively treated in terms of addressing other aspects of the cancer journey, such as fertility, nutrition, sexual health, and integrative oncology, not just the medical treatment of their cancer. Because of the high rates of psychosocial distress in this population, we also offer comprehensive psychosocial support, with having a dedicated social worker who has expertise in the care and research of young patients with this disease. And she has done a tremendous job in customizing programs tailored to meet the unique needs of this population. Because many of these young patients are unfamiliar with the healthcare system, we also have a dedicated program coordinator to help with patient navigation and to act as a liaison to the clinical and research teams to help patients have a better time navigating the system. And then finally, we do believe in a personalized treatment approach where every single young onset colorectal cancer patient does get their tumor genomically profiled with our OncoPanel assay. And then metastatic colorectal cancer patients who are young do have their reports reviewed by a molecular tumor board as part of a GI target program that then matches them to off-label therapies or clinical trials that match the genomic profile of their tumor. And with all these innovations, we really have come up with a new care model for young onset patients. And one silver lining of the pandemic is that everything shifted to Zoom. And so for the first time, our group was one of the first to be able to offer support groups and educational webinars over the web and in a virtual format, so that not only could patients at Dana-Farber take advantage, but also beyond the walls of Dana-Farber. And these are just examples of some of the programs we've been able to offer young onset patients around the world. In terms of the second mission of raising education and awareness, this is so important given the lack of awareness that this disease can happen in young people. And because young patients often feel isolated in their journey because the average age of diagnosis of colon cancer is in the late 60s or early 70s, one of the goals of our center is to offer a community of support for these young patients. And several ways that we do that include issuing a quarterly newsletter, updating on advances in this space, as well as highlighting patient stories, having a young onset patient family forum, which unfortunately has had to be virtual in the last couple of years due to COVID. And then also efforts to educate the healthcare professional community about the fact that young onset colorectal cancer is rising. We initiated a new webinar series called Gut Instincts, specifically targeted to the healthcare community. And we are active on Twitter, where so many of us do receive our latest research and scientific news. And it is also important to have a national platform to talk about colorectal cancer, as well as advocate for the importance of screening. Unfortunately, Chadwick Boseman did die of young onset colorectal cancer in his early 40s, but I do think the legacy of this tragedy will be that he will have raised awareness of this disease and the importance of screening, as well as highlighted the disparities in this disease by race and ethnicity. And so with that, I do think that more and more people now are aware that colorectal cancer can happen in young individuals and that people should start to get screened at age 45. We've also been advocating with the NCI to really set a priority for funding in this area. Compared to other diseases, given the prevalence of colon cancer, funding dollars are really not where they should be in terms of this disease. So helping them to set their funding agenda for this disease has also been one of the goals of our center. And then finally, conducting a multidisciplinary research effort to really understand what the underlying causes are. So this is the framework that I often talk about for thinking about the potential mechanisms about underlying why this might be increasing in recent decades. The first is that this is really just the same disease, but for some reason it is occurring in younger and younger individuals. And for this approach, we've taken the fact of identifying known risk factors for colorectal cancer overall and focusing on the ones that have significantly increased in recent years that may have led to this rise in young onset colorectal cancer. But again, there is also a very distinct possibility, number two, that colon cancers that happen in younger individuals may actually be different biologically. And the second possibility is a lot harder to study because you have to then consider other recent environmental exposures that have come onto the scene that may not traditionally have been associated with colorectal cancer, and then hypothesize about underlying mechanisms. In regards to the first possibility, we are fortunate to have access to the Nurses Health Study 2, which is an ongoing prospective cohort study that enrolled nearly 120,000 healthy female nurses who were aged 25 to 42 back in 1989 when the study first started. They fill out questionnaires every 2 years about standard risk factors and their medical history, and every 4 years they fill out a validated diet and lifestyle questionnaire. Back in 1998, blood and urine samples were collected as well for correlative studies, as well as questionnaires about early life exposures, which we do feel are very important for colorectal cancer. And then very recently in 2018, a very exciting effort started to collect stool samples from these healthy nurses to hopefully look at microbiome correlates of chronic disease and cancer. And because this is a cohort of female health professionals, follow-up rates have been extremely high in each questionnaire cycle. So using this cohort, we have looked at several different risk factors, with obesity being a leading hypothesis underlying why the incidence of colorectal cancer may be increasing. As we all know, the rates of obesity have skyrocketed both in children and in adults in recent decades. And indeed, among this cohort of healthy female nurses, those who did report a body mass index of 30 kilograms per meter square or higher did have significantly increased risk of developing colorectal cancer at an age under 50, even after multivariable adjustment for other potentially relevant factors. And when we queried them about weight change since 18 years of age, again, because we do think early life exposures and long-term exposures may play a significant role in the development of this disease, those women who reported significant weight gain of 40 kilograms or more since age 18 had more than a doubling of the relative risk of colon cancer at a young age. However, not all studies are consistent in showing this association. In this registry study that tried to link rates of obesity between the years of 1995 to 2005, with subsequent risk of colon cancer in the subsequent 10 years, there was no significant correlation actually. And if you talk to myself and other colleagues who have been seeing a lot of these young onset patients in clinic, we can all tell you that the vast majority of these patients are not obese and actually live very healthy lifestyles and follow healthy diets. So clearly it is not just obesity. Another risk factor that we have looked at in this Nurses Health Study 2 cohort is sedentary behavior, and particularly TV viewing time, because this particular sedentary behavior is associated with other potentially harmful lifestyle habits, as well as uninterrupted social cues for the sedentary behavior, which we think may be contributing. So among these women, young, healthy female nurses, those who reported over 14 hours per week of sedentary TV viewing time, again, has significantly higher rates of developing colorectal cancer at an age under 50. And when we broke it down to look at colon cancer versus rectal cancer, the association was significantly stronger for the development of rectal cancer, which certainly lends biologic plausibility to sedentary behavior being a potential contributing factor, given that the vast majority of young onset cancers that happen are rectal cancer. Another health and lifestyle factor that we've looked at is sugar sweetened beverages, which clearly have skyrocketed in recent years as well. And again, those women who do report over 2 servings a day of sugar sweetened beverages had over doubling of the risk of developing colon cancer at a young age. And when they answered questions about their sugar sweetened beverage intake in adolescence between the ages of 13 to 18, there was an even stronger association between that early life dietary habit and the subsequent development of colon cancer in young adulthood. And then finally, our latest study looked at vitamin D intake, which I have been investigating in metastatic disease, but it certainly does seem to play a role in the development and incidence of colorectal cancer as well, where among these young, healthy female nurses, those who reported sufficient amounts of vitamin D intake from the diet or supplements have significantly lower rates of early onset colorectal cancer, about half of the risk of developing this disease at a young age. We also looked at young onset adenomas, which are the precursor lesions to colon cancer. And again, people who did report sufficient amounts of vitamin D intake from diet and supplements has significantly decreased risks of developing polyps at a young age as well. So, the ideal way to study this, clearly it isn't any single risk factor, but a compilation of all of these acting in concert that is increasing the risk in adulthood of this disease. But the ideal way to study this would actually be to start in very, very early life, even in the conception stage in utero, and then to follow individuals slowly over time as they enter infancy, childhood, adolescence, and finally adulthood, surveying them about various diet, lifestyle risk factors and medical conditions, and also collecting biospecimens. But clearly a study like this is not feasible, both due to the cost as well as the amount of time it would take to really arrive at some answers. And so other ways to try and study this and elucidate underlying risk factors are needed. So what are some things that our Young Onset Colorectal Cancer Center are trying to do to facilitate this research? One of the ways that we are doing this is by launching a new prospective cohort study of young onset colorectal cancer patients called the Beyond CRC Project. And why do we need another cohort study? So currently, unfortunately, fortunately for the people, for the individuals participating, but there are a limited number of colorectal cancer cases right now. The Nurses Health Study 2 cohort that I mentioned, out of the 120,000 female nurses, currently only has about 110 diagnoses of young onset colon cancer in that population. And so while that is definitely a good thing, it makes it difficult to try and answer some of these epidemiologic questions about risk factors. The Nurses Health Study 2 is also one of the cohorts that has limited racial, ethnic, and geographic diversity. And many of the cohorts out there that have been utilized to try and study young onset colorectal cancer do not have collection of stool specimens for evaluation of the microbiome. They don't have uniform or validated collection of diet and lifestyle data. And many of them do not have good annotation with genomic correlates or clinical information. Many also only collect biospecimens or samples at a single point in time versus serially over time, particularly as patients progress through treatment if we want to understand what might be different about young onset colorectal cancer in terms of survival. And so the objectives of our Beyond CRC project are to one, improve our understanding of what these risk factors are and what the biology is, and then to leverage that knowledge to discover novel means of prevention, early detection, and treatment. And so every patient diagnosed with colorectal cancer at an age under 50 is eligible to participate and is approached at their first visit for consent. We are also enrolling a control cohort of healthy young patients to serve as a reference group for many of our analyses. And what we hope to do, because colorectal cancer is such a complicated multifactorial disease, is to have comprehensive collection of clinical data and biospecimens, including archival and fresh tumor tissue, germline and somatic DNA, serial blood samples as well as stool samples, collection of clinical data throughout, including clinical demographic factors, treatment information and survival outcomes, as well as validated diet and lifestyle information using a validated questionnaire. And we have an aggressive and ambitious agenda to try to collect serial specimens over time as patients undergo various treatments. Again, to look for what the biologic correlates are of response and resistance to treatment, particularly to immunotherapy agents. And so with a comprehensive cohort and biobank like this of young onset colorectal cancer patients, these are some of the questions that we are now starting to work on as we accrue more patients to the study, including comparing genetic variation, gene expression, and protein expression between younger onset and older onset patients, looking at features of the tumor immune microenvironment and what might be different, as well as the gut microbiota. And then hopefully leveraging some of this eventually to develop non-invasive technologies for screening and early detection. Because while colonoscopies are very effective, certainly the uptake of that screening test is not perfect. And finally, biologically, are these young onset cancers more aggressive because there is no gain in survival despite these patients receiving more treatment and being healthier? And so we've started to look at some of these questions, and in an early study, again, with very small numbers right now, we have conducted some multiplex immunofluorescence assays to look at specific immune cells in the tumor microenvironment of early onset versus intermediate onset versus later onset colorectal cancer. And this is a study done using the Nurses Health Study and Health Professionals Follow-up Study cohorts. And preliminarily, we do seem to see lower levels of tumor infiltrating lymphocytes around younger onset tumors. And tumor infiltrating lymphocytes certainly has been correlated with better survival. So again, just beginning to delve into what some of the biological differences may be. And ultimately, what we all hypothesize is going on is that this is going to end up being a complex interplay of diet and lifestyle exposures, as well as other environmental exposures, perhaps antibiotic use, leading directly to the development of cancer, but also shaping the gut microbiome and influencing host metabolism and immunity to lead to increased susceptibility to this disease at younger ages. And so with the launch of our center in 2019, our volume of young onset colorectal cancer patients has steadily increased, which we feel gratified by because we hope that this means that more and more young patients are getting the comprehensive care that they need to optimally treat their cancer, but also participating in some of these research opportunities. With those numbers, though, it will still take way too long. And so in order to accelerate the pace of research, we do have plans to expand beyond CRC to be a national and international multi-center study. And so we currently already have existing collaborations with UCSF as well as St. Luke's Cancer Institute in Idaho, and established collaboration with the HIO in Barcelona, and hopefully very soon the Oncoclínica's community cancer clinic practice network of cancer practices will be joining the study as well. And then in order to even further expand our ability to accrue patients to these studies, we have also launched a Count Me In colorectal cancer project, where for those of you who are not familiar, Count Me In is a digital social media platform that directly engages and partners with patients across the United States and Canada for participation in research. And in this way, because we are then not limited to patients who are seen at one of our participating sites and beyond CRC, it will allow for much more rapid accrual and collection of biospecimens and data, as well as enhancing diversity and inclusion in our research study in terms of racial ethnic factors, socioeconomic factors, as well as geography. And importantly, a mechanism like this to conduct research allows research to continue even during pandemic times. So with that, I just want to quickly acknowledge the very many collaborators and institutes that have helped with this work, both in terms of launching our Young Onset Colorectal Cancer Center, but also with all the epidemiologic studies that we are doing, as well as the Beyond CRC project. And my funding sources are listed here as well. So thank you so much for your time and attention, and I'm happy to take any questions.
Perfect. Thank you so much, Dr. Eng, for this sobering but yet comprehensive tour de force work that you presented, and for all your advocacy. So first of all, let me also remind everyone to keep the questions rolling into the Q&A, and we'll start with a couple of them. So one question is, maybe I'll rephrase it a little bit. It says, did you consider offering young age colonoscopy to your study cohort? How was that trade-off made? And maybe I can also add to that, how do we also think about sampling maybe family members or normal controls for some of those studies, perhaps? What is the role of colonoscopy in our study cohort?
Yes, so as we mentioned, the U.S. Preventive Services Task Force recently lowered the age at which to start screening to age 45. And the importance of this recommendation is that because of the Affordable Care Act, insurance companies are now obligated to cover recommended cancer screenings from this task force for all average risk individuals. But clearly, this doesn't mean that colonoscopies are going to be covered for people under the age of 45. And so this is where it's really important to understand risk factors as well as family history. And one very big public health campaign is to better document a comprehensive family history, both in terms of first-degree relatives who have a history of colon cancer, but also advanced polyps. Because if there is a documented history such as that, then colonoscopies and other forms of colorectal cancer screening will be reimbursed by insurance starting at an earlier age, at age 40. Now, for our existing young onset colorectal cancer patients, if a germline genetic predisposition is not found, we typically recommend that their first degree family members start colonoscopy screening at an age 10 years younger than the age at which our patient was diagnosed. So if a patient was diagnosed at age 35, their children need to start colorectal cancer screening at age 25.
Perfect. Thank you so much. One question pertains to symptoms. It's also in the chat. Are there any specific, unique, or more prominent symptoms in early onset colon cancer, which one should be paying perhaps more attention to?
That's a great question. And actually, several studies have looked at it. What are the most common presenting symptoms in young onset patients, and are they different than older onset patients? And the one that actually comes to the top of the list in almost every study is blood in the stool. So because most of the cancers that happen in younger people do happen on the left side of the colon and in the rectum, one of the first presenting signs of these types of cancers is bleeding in the stool. So by far, that should be the one symptom to look out for. Others that are common include abdominal pain, a change in bowel habits or the caliber of the stool, unintentional weight loss, as well as anemia that is not otherwise explained. But the most common symptom among our young patients is rectal bleeding.
Perfect. And I guess related to that, if I may ask another question, in terms of the sidedness difference, hopefully any thoughts as to why that may be, or any, candidate thoughts, I guess?
We actually have no idea, really. There are certainly genomic differences depending on whether your primary tumor is occurring on the left side of the colon or the right side of the colon. So could those be, contributing to these differences? I think deeper sequencing analyses, such as ones that we're doing, will hopefully help to elucidate that question. The other hypothesis is that the gut microbiome, the gut microbiota may be contributing here as well, because the microbial communities of the left side of the colon are quite different than the right side of the colon. So as we better characterize and sequence the microbiota in these different parts of the intestinal tract, we will hopefully start to begin to understand whether there are microbiome contributors to those differences.
Perfect, thank you. Another question pertaining to animal modeling that addresses the question of in utero exposures resulting in predisposition to GI malignancy.
Yeah, I think it's a great idea. I don't know of any studies going on right now, but certainly, I think that would be an interesting way to try to get at in utero exposures and how they might be contributing to the pathogenesis of this disease.
Yeah, and Eva also asks whether we know anything about microplastics. Again, probably something to worry about.
Yeah, microplastics has come up as a potential hypothesis as well. It's absolutely everywhere. I think measuring microplastics in the available cohorts of individuals that we have in order to study this question is limited. And, such as the Nurses Health Study, Health Professionals Follow-up Study, we're still trying to quantify the ways that we can actually measure exposure to microplastics. So I do think there will be more to come on that, but still a work in progress.
Sure. There's a couple of questions pertaining to the outreach efforts, including one for Count Me In. So the question is, in using Count Me In to increase racial ethnic diversity, what are you doing to reach these minority populations?
It's a great question. And I do know that the Count Me In group has been dedicating a lot of time, effort, and resources into this. And I think one of their main strategies is to partner with local community leaders, both to raise awareness about cancer screening in those populations, but also to inform them about this opportunity and this research study, and to encourage participation.
Perfect. And along those lines, is there anything that we could be doing, healthy folks can do to help out with this mission? And a second related to question, are there any ways to support your research at Dana-Farber?
Yeah, so as I mentioned, it's a great question. We are interested in having healthy young people participate in some of our studies. For a lot of our analyses, it's often useful to have a control population who doesn't have cancer to help with interpreting the results of our analyses. So certainly looking for opportunities to participate in healthy control research is great. But also just, talking to your family about their family history. And not there is a stigma associated with talking about colorectal cancer and some of the symptoms that happen with colorectal cancer. And I think that stigma and the reluctance to really talk about these things is greatly affecting awareness and the ability to do prevention and early detection. And so, being open to talking about symptoms, seeing a doctor, and also learning family history and asking about family history will be very important.
Perfect. There is a question you mentioned and went over beautifully, the effects of COVID on screening and so forth. This question pertains more to biology. Do we have any insight into the effects of COVID exposure on CRC disease rates?
I don't think we know yet. I do think we know that COVID is detected in the gut and can be still found in the gut even after infection, and certainly is detectable in feces. But the impact of COVID-19 infection on colorectal cancer incidence is currently unknown. It's certainly intriguing, right? Because certainly it'll affect the microbiota and the community in the colon. So I assume there will be more research on that and more studies on that coming forward, but we don't know right now.
Right. I think that may be coming from Bob, actually. So one of the early slides demonstrated the decrease in incidence both in younger and older people through the late 70s before this birth cohort happened, where now we had increasing trends in young onset patients. Assuming that there's a 15 to 20 year latency between a carcinogenic or epigenetic exposure, what might have occurred in the early 50s in terms of some of these epidemiologic factors, such as diet or lifestyle?
Yes, and I think that's one of the main ways we're trying to focus and direct the epidemiologic studies that we're doing. And so that is why a lot of studies have focused on obesity. That has certainly skyrocketed in recent decades. Westernized diets have also skyrocketed in recent decades. And in some of those countries in the Mediterranean, the Far East, where there had been recent Westernization of lifestyles, we are now starting to see higher rates of colorectal cancer in those populations as well. And so I do think changes in diet and lifestyle are probably underlying this. There has been less physical activity in recent decades. There has been higher rates of vitamin D deficiency occurring. And so all of these factors that we know are strongly linked to colorectal cancer incidence, no matter what age you are certainly strong hypotheses for why this disease might be occurring earlier and earlier.
Great. And I guess a question related to, maybe to paraphrase it, the question is about a specific risk factor, obesity, whether obese adolescent patients, for example, are screened earlier, or is it still under the guidance that you mentioned? And paraphrasing that again, based on the epidemiologic factors that you just went over, is there any thought to adjust screening guidelines?
Yes, I think that will be the future of screening, actually, because I don't think it's feasible or will be cost effective to offer colon cancer screening to everybody, starting at age 18. And so I do think the way to start to detect and screen individuals is to identify who is at high risk. So which of the young patients are at high risk, and is this determined based on a diet and lifestyle risk score? Is it a combined score with, germline genetic variation or other genetic variation? I think that people are working on that, and whether we can come up with a risk-adapted approach to really identify the young people who are at highest risk of developing colon cancer and to adjust the age at which to start screening based on a risk score such as that.
Perfect. It's very interesting to see this topic generating so many questions and excitement. But with that, we'll go to the last one, I promise. And the question is if there's any progress on making a Cologuard test that is focused on these patients.
Yeah, so Cologuard, which is a mixed fit with DNA test, is FDA approved for individuals starting at age 45. And a lot of primary care doctors are actually offering stool-based tests and Cologuard tests for these younger individuals who may have a more difficult time, for example, taking time off work to go get a colonoscopy. And because rectal bleeding is one of the major presenting symptoms for these young people who are being diagnosed with this disease. I do think there are a lot of other efforts to come up with other non-invasive tests that may even be better than Cologuard. Cologuard and stool-based tests are predominantly good at finding early cancers. They're not as great at finding polyps. And so for cancer prevention and decreasing the incidence of disease, stool-based tests are not as good as colonoscopies. They are good at, they are effective for decreasing mortality because then you do find these cancers at an earlier stage. But I do think in the future, we need a better stool-based test, perhaps that's based on the unique microbiome features of young onset colon cancer, or maybe other blood-based markers where we can have a better non-invasive test for screening and early detection.
Perfect. And with that, I think all the questions have been answered, and we want to thank you again, Dr. Eng, for this outstanding talk and all your research and clinical leadership in this field.
Thank you so much for having me.